So good evening, everyone. Welcome to this ISN Web Masterclass 2021, the first of its kind. And we are straight into the pre-webinar quiz session. All the best for this quiz session. The rules of the quiz are myself and Dr. Santosh will be taking care and we'll be posing the question to you. And once the question is on display, you have to read the question and answer it all within 30 seconds. And after 30 seconds, the responses you give won't be recorded. We'll be showing you the answer slide after the 30 seconds are over, and then we move on to the next question. And where do you have to fill your answers? On your screen, you can see a box on the right where the options will be displayed, and you have to click on the correct answer. So remember, do not put your answers in the chat box. You have to click on the choices given there. So all the best. I hope all the postgraduates are attending the quiz. This is a pre-webinar quiz, and let us see how many you get right before we discuss the glomerulonephritis. So Siddharth, can we have the first question? Which of the following entities is associated with the highest rate of resistance to initial immunosuppressive therapy? The four choices are there in front of you. So the 30 seconds are up. Log the answers in the question. And can we have the answer slide, please? The answer to this question is FSGS collapsing variant. It has only 10 to 20% remission and membranous nephropathy 70% remission. So that's the first question for you. Santosh, can you go to the next question, please?
The second question is as follows. A 42-year-old male comes to you with a recently diagnosed minimal change disease and asks you about his future disease course. All the following answers are true except time's up. Lock the question. Can we have the answer, please? So the answer is all the following are true except once in remission, relapses are rare. The studies show that up to 73% can have one relapse and about 44% can have more than one relapse. Next question, please, ma'am.
So a 24-year-old patient presents with severe nephrotic syndrome. Kidney biopsy shows minimal change disease with minimal tubulointerstitial fibrosis and diffuse tubular injury. Serum creatinine is 4.8 milligram per DL and he is oliguric. Prednisolone 60 milligram per day is started. What is your expectation on his clinical course and treatment? So the time is up. Please log the question. And can we have the answer, please? The answer is, this is a patient of minimal change disease. Though the creatinine is high, he is still likely to recover renal function significantly and the steroids should be continued. AKI can occur in 20 to 30% of patients at presentation. Risk factors of AKI are heavy proteinuria, male gender, age more than 50, history of hypertension, and arteriosclerosis on kidney biopsy. Dr. Santosh, over to you for the next question.
An 8-year-old boy comes with nephrotic syndrome after 1 month of 60 milligram per meter squared per day of prednisolone. The patient is persistently nephrotic. Which of the following agents should be used at this time? Time's up. Log the question, please. Now the answer. The answer is the calcineurin inhibitor cyclosporin. Recent data shows that in steroid nephrotic steroid-resistant nephrotic syndrome, CNIs are more efficacious than other drugs that were tried against them. Over to you, ma'am, for the next question.
So a 33-year-old patient with no past medical history is evaluated for proteinuria, physical examination 150 by 90 blood pressure, BMI 30, no edema noted peripherally and no other abnormalities. Serum albumin is 3.8, creatinine is 1.5, cholesterol 250, urine protein 6 gram, and acellular urine sediment. Kidney biopsy is performed, which shows enlarged glomeruli and lesions of FSGS. What's your treatment strategy? So I think the time is up. We can log the question now. And can we have the answer slide, please? So in this case, you can see that weight control, blood pressure control, and RAS blockade is the answer. And why is this so? This is because the combination of an absence of full nephrotic syndrome, this patient had a normal serum albumin, glomerulomegaly, and a higher form of FSGS suggests that this is a secondary maladaptive form of FSGS. Immunosuppression, hence, is not indicated. And conservative measures include aggressive BP and weight control and optimizing the RAS blockade. And that's why the choice one is the correct answer. Over to you, Dr. Santosh, for the next question.
Which of the following treatments are not indicated for frequent relapsing or steroid-dependent minimal change disease? Okay, time's up. Please lock the question. Can I have the answer slide, please? So levamisole, cyclophosphamide, rituximab all have been found effective in frequent relapsing and steroid-dependent nephrotic syndrome, while ACTH has not yet been found to be useful. Over to you, ma'am, for the next question.
So choose the odd one out. This is simple. So log the question. May we have the answer now? Can we go to the answer slide, please? So as is very clear, all of them are associated with proteinuric diseases except polycystin, which is located on the cilia. The others are on the podocytes. So odd one out is polycystin. Over to Dr. Santosh for the next question.
So in a patient with congenital nephrotic syndrome of the Finnish type, which of the following statements is true? Okay, time's up. Please lock the question. Can I have the answer slide, please? So the answer is that even the Finnish type nephrotic syndrome of the congenital type nephrotic syndrome responds to ACE inhibitors partially in at least in quarter of the patients, as can be seen in the study. Over to ma'am for the next question.
So which of the following is not a clinical presentation of IgA nephropathy? You log the question, and can we have the answer slide, please? So we all know that the common presentations are gross hematuria, asymptomatic microscopic hematuria, nephrotic syndrome in less than 5%, RPRF, AKI can occur though rare, and chronic kidney disease. Thrombotic microangiopathy is not generally a clinical presentation of IgA nephropathy. So over to you, Dr. Santosh, for 10th question.
The 10th question is as follows. Which of the following acute nephritis has a low serum complements in the individual who has a disease? Okay, time's up. Clock the question, please. May I have the answer slide? So shunt nephritis is the one where serum complement levels are low, unlike the others. Over to you, ma'am, for the next question.
So following is not a property of mucosal normal human IgA. So time's up. Can we have the answer slide, please? So as you all know, IgA is dimeric. Therefore, choice 3 is wrong, and that's the answer. Next question, Dr. Santosh, please go ahead.
Question number 12. Which of the following statements is incorrect about IgA nephropathy? Okay, time's up. Lock the question, please. Can I have the answer slide? The correct answer is part 4. Testing study shows that steroids do not have a role. Actually, the testing study did show that some benefit was there with steroid therapy, but there was a high risk of adverse events. Over to you, ma'am, for the 13th question.
So which statement is correct about stop IgA trial? So time's up. We can lock the question and move over to the answer slide, please. So all the other statements were wrong. All patients were required to be on maximally tolerated dose of RAS inhibitors is the correct option. So you can, from the trial that the reduction of rate and decline was not less in the patients who received immunosuppression. So the correct answer is option number 2. Over to you, Dr. Santosh, for question 14.
This normal, no identifiable secondary cause. Which of the following statements is incorrect? Okay, can lock the question, please. Can I have the answer slide? The incorrect answer is 3. There is no role for rituximab for an MPGN pattern with immune complex deposits. We can use steroids, mycophenolates, rituximab, cyclophosphamide. All of them are among the recommended options as per the KDIGO. Over to you, ma'am, for the last question.
Can I have the next question, Siddharth? So this is a spotter, 32 years male, presented with nephritic syndrome, with the features listed on the left-hand side of the slide. Look at his phenotype, fundus examination, and the renal biopsy. So 30 seconds are up. Log the question. And can we have the answer, please? So this is all of you must have made it out. Partial lipodystrophy and Barraquer-Simmons syndrome. And we all know that it's associated with drusen in the eye and dense deposit disease, the so-called old dense deposit disease with predominant C3 deposits on IF and intramembranous electron dense deposits. This disease recurs after transplant, and it's important that we pick this disease up. It can be done clinically as well. So that brings us to the end of our quiz, the pre-webinar quiz, and I hand it back to the organizers to carry the proceedings forward. Thank you from my side and from Dr. Santosh's side for giving us this opportunity. Hope you had a great time. Over to Dr. Gupta for taking the proceedings forward.
Narad.
Siddhartha, you can upload Professor Jayarada Krishna's slide, introduction slide.
Well, dear friends, welcome you all to the first webinar of 2021 by the ISN, Indian Society of Nephrology. As you all know, our society is committed to the promotion of teaching, training, and research. And with that in mind, when I took over in 2019 as president, we had promised to hold series of regional and theme-based meetings to provide training and education to our postgraduates in advanced nephrology. And everybody knows what happened. COVID-19 pandemic tilted everything. It made us, we could not have any meetings, including our annual meeting of ISN had to be postponed. But despite this, we had the courage to do some meetings like we carried on with the International Society of Nephrology, American Society of Nephrology, and others. And our society also conducted 1-month course of research methodology in the month of September. And now that we have a meeting coming, 2021 annual meeting, before that we had decided to hold a series of meetings, theme-based meetings for the postgraduates. The first such meeting is glomerulonephritis, second maybe either of the glomerulonephritis, second glomerulonephritis or UK, and similarly we'll have meeting every month, the second or Thursday of March. And we look forward to suggestions from our colleagues and PG students. Now coming to the, before we come to the first talk, let me Dr. Anil Balla, he's a Padam Shri and Bichira awardee, and he's the chairman of nephrology in Sargangama Hospital. He is the president of Renal Nutrition Society, as well as past president of peritoneal dialysis. And the second moderator is Dr. S.K. Agarwal, Chief of Nephrology at College of Medical Sciences. He's editor of Indian Journal of Nephrology, and he has varied assignments in the government as well as Commonwealth Fellow earlier. Of course, we must thank Dr. Manisha Sahai, Chief of Nephrology at Osmania Medical College. She's a member, executive member of the Executive Council of Indian Society of Nephrology, chair of ISN South Asian Board. She's editor of Indian Journal of Transplantation, and she was there already with the PG quiz. Similarly, Dr. Santosh Varghese, Chief of Nephrology at the Christian Medical College, Bangalore. He was also with Dr. Manisha in conducting the quiz, the pre-webinar, and they will also be coming back the question and answer later. Now, coming back to today's session, we have got 3 talks. First talk is going to be delivered by Dr. Jayarada Krishnan, that is on photocytopathy, understanding and management. Who doesn't know Dr. Jayarada Krishnan? He is always very well known to all of us visiting India, and we feel pleased to invite him. Just for the juniors to let them know, Dr. Jayarada Krishnan is Professor of Medicine, Columbia University, New York, and he's a clinical chief of nephrology division in the New York Presbyterian Hospital. His clinical research is in wide areas, but especially in chronic kidney disease and glomerular diseases, and of course intensive care. I know he has been associated with kidney and heart and cardiorenal syndromes. He's an associate editor of Kidney International and a founder editor of Kidney International Reports. He is an active member on various committees of American Society of Nephrology, International Nephrology, and of course, his commitment to medical education is very well known. Whenever he comes to India, he always makes a point to give talks in different institutions, including PJ Chandigarh, where I was working before. With this, I open the session to Dr. Jay. Can you please speak on the advances in the understanding and management of photocytopathies, which is we are dealing day in and day out. In common parlance, it is just minimal change in focal segmental glomerulosclerosis and the genetic variants, but in management and understanding, there's a lot to learn. Dr. Jay, over to you.
Thank you, Dr. Gupta, and thank you to all the organizing committee members for inviting me. It's a pleasure to be here again, although virtually would have really preferred to be in person. So the topic of today's talk is about photocytopathies, and a lot of things have gone on. And I think what I'll talk about today is just to give a brief overview of what's behind the biopsy finding of a photocytopathy, and then some of the upcoming KDIGO guidelines. So these are some of my disclosures. You know, I have done research on this study from a variety of industrial organizations. I've written up-to-date chapters, and I'm part of the KDIGO GN guideline committee. So just a quick overview on the epidemiology. So it's now the leading glomerular cause of end-stage kidney failure in the US. And worldwide, it's also not uncommon. Although it's a rare disease, it's really growing in number. So 0.1 out of 100,000 in children and 0.8 in adults. And during the last 2 or 3 decades, the incidence has really gone up from 3 to 13-fold, depending on which study you look at. And it's actually, in some countries, it's approaching IgA nephropathy in terms of being one of the commonest GNs. So overall, not only the incidence, but the prevalence is growing. And if you come down to the bottom left, 20% of children will have FSGS as their primary cause of nephrotic syndrome, and 40% of adults. So we are now in a situation where we need to recognize this and treat appropriately based on some common guidelines that we have developed. So what is behind a podocytopathy? It always starts with podocyte injury. And then how does the podocyte respond? If there's no change in the podocyte number, we see no changes in histology, and we call this minimal change disease. On the right side, if there's a proliferation of podocytes, it can be a low number of cells that are proliferating, and we call this mesangial sclerosis, or DMS, diffuse mesangial sclerosis, which is almost exclusively seen in children. And if there is a high number of podocyte proliferation and the indices are very high, there's dedifferentiation. We call this collapsing glomerulopathy. And in the middle, what is happening here is the injury leads to death or detachment of the podocyte, and it leads to segmental sclerosis. So if you look and see what's behind that, here's a normal podocyte and a normal capillary loop, and here's the podocyte. There's the Bowman space, and here are the parietal cells on top. So when you denude the basal membrane or the podocyte, the parietal cell tries to fill up this detached, this open membrane. And in doing so, unfortunately, it doesn't lead to repair, but it leads to a synechia forming as a first step. And then finally, that leads to a scar, which then comes inside the capillary loop. And now you see the classic finding of FSGS in that capillary loop. So this is the so-called Columbia classification. And the way this was done is to see if we can find a prognostic association with each of these descriptors. So on the bottom left is collapsing. So if you see one gloom with a collapsing finding, you call this collapsing. On the next is the tip variant. It's right next to the exit proximal tubule. You see sclerosis there. We call this a tip variant. If you don't see collapsing at tip and you find endocapillary proliferation, we call this a cellular variant. And then the perihilar variant is quite unique because it's very close to the vascular pole. And this implies that there is actually a hyperfiltration. Many of these patients have what we call the hyperfiltration or adaptive form of FSGS. And if none of these are seen, then we call this NOS, not otherwise specified. So this is an iterative classification going from collapsing all the way to NOS. And the question is, so what? So this was answered very nicely in the focal segmental clinical trial, where patients were randomized to MMF DEX in one group and cyclosporin with steroids in the other group. And you can see right here that collapsing still has the worst prognosis compared to TIP, and NOS is somewhere in between. So one of the ways you can sort of try to prognosticate based on the initial biopsy is to see where this lesion is, what this lesion is, and then collapsing is not so good and TIP is actually quite good. So the thing that we tried to describe in the KDIGO guideline was okay, you've seen FSGS on the light microscopy, and okay, it might be TIP or collapsing, but what is behind the lesion? Can we find a cause, underlying cause? Because that'll make a big difference in how you treat the patient. So the word primary FSGS is described to a patient who has diffuse food process effacement and full nephrotic syndrome. And these patients are often have sudden onset of symptoms. And this is the only group that you will essentially treat with immunosuppressive therapy. And there are some clues as to what separates primary from the rest. And the implication here is that these patients have a circulating factor derived from some discord in the immune system that leads to podocyte dysfunction. Now, genetic FSGS can be familial and syndromic if you're able to diagnose this clinically. But increasingly, we have to revert to performing either a whole exome sequencing or a targeted sequencing to try and see what's behind the patient's genetic makeup. Then the secondary FSGS we reserve in three categories: viral, and very classically it's HIV, parvovirus, and most recently COVID-associated nephropathy, COVAN. There are many drugs that can do this, and then the most common cause probably is adaptive changes, which, because of either normal or reduced nephron mass, there's an increase in hyperfiltration, and that leads to, in certain patients, a segmental food process effacement, and then you get proteinuria. And typically, this is without nephrotic syndrome. And finally, there's a group that we cannot easily put into the previous three categories. There are no known associations. Food process effacement is segmental. You don't get the full proteinuric syndrome, the nephrotic syndrome. And again, no signs of any secondary or genetic cause. So this is the way we are trying to differentiate the primaries, which would require treatment, versus everything else. So if you have proteinuria above 3.5 grams, the most next thing to look at is serum albumin. So if it's below 30 grams per liter or 3.0 grams per deciliter, and edema is not important, we call this nephrotic syndrome. And when you have diffuse food process effacement, it's very likely that the patient has primary FSGS. And in these patients, we would prescribe immunosuppression. And again, if there's no response, some of these patients, especially younger patients, would have a genetic cause. And we strongly recommend doing a genetic test before going on to more immunosuppression. If you do not have the nephrotic syndrome, in other words, you may have 3.5 grams or higher, but serum albumin is above 3 grams per deciliter, 30 grams per liter. Or if you have lower levels of proteinuria with or without hypoalbuminemia, we would look very carefully for a secondary cause. And again, in this group, maybe start with genetic screening, and definitely do not start immunosuppression, but simply give supportive therapy and keep monitoring. If there's worsening proteinuria, and especially if there's a reduction of serum albumin, we go into this box here, primary, and then consider treatment with immunosuppression. So I'm not going to go into the above 60 monogenic mutations, but one important thing is it's not just the podocyte proteins, but in adults especially, GBM protein mutations, the collagenopathies, can present with FSGS lesions, sometimes without the full features of Alport syndrome, including in the electron microscopy. You don't see the classic GBM changes. So this is something to keep in mind, especially if there's a family history. So how do we approach genetic testing? So there are selected patients, clearly, who have a genetic background for FSGS. And again, like we said, this could be familial, sporadic, syndromic, or collagenopathy. So this latter category is very important, and one shouldn't just look only for podocyte proteins, but also for collagen proteins in such patients. Why would it help our patients? Helps in diagnosing, of course. If you cannot make a clinical diagnosis of a syndrome, especially, very importantly, you don't need to immunosuppress these patients. Clearly, beyond steroids, if you have a genetic mutation, there is absolutely no role at this present time to treat them with rituximab, cyclophosphamide, and such like. The risk of recurrent disease is very low in kidney transplantation, with a few exceptions. Perhaps with the congenital nephrotic syndrome, you may get a proteinuric relapse from antibodies. Donors are very important. If you have a patient with a familial FSGS, one needs to be sure that the donor doesn't have the same condition. You may aid in prenatal diagnosis and choose an embryo which does not carry the mutation, and then other family members. So the single most important prognostic sign is whether or not your patient goes into remission. So full remission is a very good chance of kidney survival compared to no remission. So your chance of making it out 5 years is less than 50% in patients who do not remit. And this is the second obvious reason is the higher the proteinuria and the worse the kidney function at the time of presentation. Prognosis is worse, as also collapsing forms of FSGS. So when we look at the management, excuse me, what we said in the KDIGO guideline is that if you have uncertain cause and secondary, do not immunosuppress. And this is a bit of a problem because a lot of times you cannot tell, and we may have to do this course of immunosuppression. But clearly, if your serum albumin is not low, I'm going to say this again, it's best not to immunosuppress these patients until such time that the serum albumin drops, and then keep trying to use conservative management. So when you come to minimal change disease, nothing is really changed. Once you make a diagnosis on biopsy, and if there's no contraindication of steroid, you start with corticosteroids. And if there are contraindications, cyclophosphamide short-term, 2 months, 3 months is fine. Calcineurin inhibitors, mycophenolate with reduced dose corticosteroids, all these are being checked in clinical trials and have found to be as good as steroids. And then there's some emerging data on rituximab as first line, but it's very small, but it seems to be effective. But the key point here is that we should not force steroids if the patient doesn't want to. So the choice is not only based on your assessment of whether there are contraindications, but also if the patient prefers this other categories and drugs or not, because they're found to be equally effective. And one does not need to expose patients to steroids since many other drugs are now available. In patients who relapse frequently or who are dependent, and if they haven't had previous cyclophosphamide, still cyclophosphamide is quite useful. But in patients who do not wish to receive cyclophosphamide or have had previous exposure, again, the three groups, rituximab is now probably the most favored drug, but there are cost issues. Of course, calcineurin inhibitors and then mycophenolic acid analogs are all equally effective. For FSGS, again, high-dose steroids is first line, and the dosing schedule is essentially milligram per kilo or 2 milligrams per kilo every other day. And how long? 16 weeks maximum, or whenever the patient achieved remission. And from that point, you can start tapering. And then how long should you give it for? Totally, it's at least 6 months. So the definition of complete remission in FSGS is if you need to go under 0.3 grams or 300 milligrams per gram on a ratio, and the serum albumin needs to go above 3.5. So that's complete remission. Partial remission is 0.3 to 3.5, and a decrease of 50% from baseline. So this is quite a restrictive definition. So what other investigators have shown is that an easier way to look at partial remission, and in fact, remember, partial remission is a good endpoint to achieve in FSGS, is simply 40% proteinuria from baseline, and it should go below 1.5. So if you reach this, the prognosis is almost as good as complete remission. And in fact, the newer trials are using this modified endpoint in terms of if the patient is going to do well or not. So in patients who have relative contraindications to steroids or are intolerant to steroids, you can use calcineurin inhibitors as the only second-line agent. And if you're resistant to steroids, again, either cyclosporin or tacrolimus. The minimum period is 6 months before saying it's not effective. And then how long? Once you achieve remission or you respond, you don't have to achieve full remission. It's 12 months. But the reality is if you're in partial remission, most of my patients stay on this for indefinite periods of time at the lowest level that keeps them in at least partial remission. And if you do not tolerate or respond to CNIs, so you failed both drugs, then essentially this patient should be referred to a center that specializes in FSGS. And there are some alternatives which are essentially in the form of clinical trials. So how are we doing with FSGS? So people who don't respond, as we said, half of them will go on to kidney failure in about 1,000 days. And this 5-year 50% is very, very prominent right now. If you don't respond at all, your chance of hitting dialysis or transplant is 50% at 5 years. So we need at least partial remission, and we're hoping we can do this. So what is the percentage of children who do not respond? 47% of children, 38% of adults. And this is a big unmet need in the area of FSGS. So I'm going to conclude with emerging therapies. So if you look at the two systems, angiotensin 2 and endothelin 1, which is more recently recognized as a podocyte toxin. So not only does it affect podocytes, but the entire glomerular components. So in the kidney vessels, a vasoconstriction, the endothelial cells do not function well. In the glomerulus, it causes proliferation of the mesangial cells, glomerulosclerosis, and deposition of extracellular matrix, then a whole bunch of podocyte abnormalities, and very importantly, over time, remember that interstitial fibrosis is the biggest predictor of prognosis. Both these cytokines cause inflammation and fibrosis. So a drug that's just being investigated and in fact is very close to clinical approval, hopefully, is sparsentan. And sparsentan has the ability of blocking both angiotensin 2 and endothelin 1 in the same molecule. So this part is AT1 and this part is ET1. And by giving one drug, you're basically affecting two mechanisms of podocyte dysfunction, which hopefully will lead to amelioration of FSGS. So DUET was a phase 2 study of this drug, and it's a dose finding trial. So there were 200, 300, 200, 400, 800 milligrams of sparsentan compared to 300 milligrams of irbesartan. And these patients were treated for a period of 12 weeks. And you can see these are the patients on the left. They were pediatrics through adults, primary or genetic. And that's an important thing because traditionally we've used immunosuppression in primary only, but since this is not immunosuppressive, it was tried in genetic causes of FSGS2. And these are the entry criteria. So what are the findings? It is quite interesting that in irbesartan, the reduction of proteinuria is about 20%, whereas it doubled with sparsentan to 44%, with similar adverse events on the right. And you can see the post hoc analysis was, look at the number of patients who achieved full remission in terms of proteinuria. So it seemed to be a dose-related effect. So altogether 41%, but as you get higher and higher in the dose, up to 50% of patients achieve this less than 0.3 grams per gram. And there was an open label extension. So there was a double blind period followed by an open label extension. And you can see right here, 28% of patients achieved this partial remission endpoint in the group that received sparsentan versus 9%. But when they were crossed over into the active drug, at the end of the open label, 50 to 60% were in this partial remission endpoint. So the next study was the duplex study, which is ongoing right now. So they simply compared 400 of sparsentan versus 150 of irbesartan that was increased to 800 and 300 if tolerated. So this is a long-term study, and we have some interim results, which is very exciting. Just released last month. So 42% of patients on sparsentan versus 26% achieved the initial endpoint of this partial remission at 36 weeks. So the hope is that this drug can gain approval based on this, but the FDA says, look, you got to complete the trial. Then we have to wait till 2023 for the full trial to be done. So the last two issues here are other drugs that are being looked at. So the NRF2 keep system is an interesting system. So in the presence of an oxidative stress, reactive oxygen species, you essentially activate this system, which produces transcription factors, NRF2, which activates a whole host of antioxidative and anti-inflammatory factors. So for example, you may have analogs like bardoxolone or this drug called CXA10, which inhibits this process by increasing levels of NRF2. And in doing so, all the things that you see with FSGS and other glomerular diseases, endothelial dysfunction, mesangial cell dysfunction, and fibrosis and inflammation are all inhibited. So the drug that's being tested right now is called CXA10, and phase 2 is complete. It's called the first trial. So the idea is that as a consequence of podocyte dysfunction, lots of downstream events happen. And hopefully this can lead to reduction in fibrosis, not only in FSGS, but in other GNs as well. And then the other drug is based on this TRPC5 channel. So TRPC5 is a calcium channel. And in response to glomerular stress, this channel opens, calcium enters, and you get a whole host of downstream events, which leads to progression of podocyte dysfunction. So there's a drug called GFP887. It's an inhibitor of the TRPC5 channel, and the Traction 2 trial is ongoing. It's a phase 2 trial. The third pathway is the SLIT2 ROBO2 pathway. And again, not to go into too much detail, but if you activate SLIT, it leads to a lot of downstream events that leads to further damage to the podocytes. So we can block this SLIT ligand. The idea is that it'll reduce some of these downstream events. And this is called the PODO trial with this Pfizer drug PF06730512. And this is ongoing phase 2 trial with primary FSGS. And then lastly, the role of lipids in causing and promoting podocyte dysfunction is being tested with LDL pheresis. So these are columns that specifically take off LDL. And in a preliminary study, you can see that 25% went to complete remission. And there was some remission in the remainder of the patients with no effect on about 1/3. So this trial is also going on in patients with FSGS, where we're taking off lipids in addition to other therapies to see if it improves the prognosis. So that was my last slide, and thank you very much for inviting me. And if there's time, I'll be happy to answer questions.
Thank you, Dr. Jai, for beautifully highlighting the pathogenesis of podocytopathy and management, including the current drugs under trial, which I hope will be great help. But basically, we come to the basic question of treating patients with minimal change focal segmental sclerosis. We find a patient, like there are some trials recently showing that we need not give prolonged treatment. Duration is not that important, even short duration good enough, unnecessarily exposing to steroid. Second thing, a patient who is having frequent relapses or is steroid dependent, to choose between calcineurin inhibitors versus mycophenolate, what do you say? And third question, role of leflunomide in childhood lupus nephritis, childhood nephrotism. Sorry to ask you.
Yeah, so I'll start with the first question is, in patients with minimal change disease. So we have no data in adults in terms of short duration therapies, but what I do is if patients respond within X number of weeks, then I put them into a rapid taper. So they are off in the next 4 to 6 weeks, because in adults, it's a relapsing disease and at least 50% of patients will relapse. And the idea is not to expose them too much to steroids because the second line drugs are equally effective. In fact, I almost never use steroids at all. Even in initial treatment of minimal change disease, I use either calcineurin inhibitor or mycophenolic acid with low dose steroids just to avoid the side effects of steroids in adults with minimal change. So the short duration trials are very well demonstrated in children. Unfortunately, within the adult category, there's a group of patients who won't respond that well. So without sort of knowing, we have to treat them for longer and longer periods of time. Hence, I don't use steroids, commonly in adults. In terms of frequently relapsing, if you're steroid dependent, the response to rituximab and cyclophosphamide are much better than with MMF or with CNI. So it's preferable to use Ritux or cyclophosphamide in the true steroid dependent. But in frequent relapsing, you can use any of the drugs. And in fact, CNIs are just as good as MMF in those patients. So I make a differentiation between truly dependent versus frequent relapses. And the third question I forgot. Can you repeat, please?
Leflunomide.
Leflunomide. It has not been rigorously tested. The big problem with leflunomide is the half-life is 28 days. So it takes a long time for the drug to reach therapeutic levels. So you have to you have to give a loading dose followed by a maintenance dose. And even if you have a complication, it takes several weeks for the effect to wear off. So I'm not in favor of leflunomide as such unless there's a cost issue or there's some other reason to use the drug above other drugs. Thank you.
There must be a lot of questions, but because of the time, we have to now stop here. We thank you for the excellent talk. Look forward to hear you again. Over to you, Dr. Balla, for the next talk.
Thank you.
Thank you, Professor Gupta. It is my proud privilege to invite Professor Vivekanand Jha to deliver the second talk on glomerulonephritis. And Dr. Vivekanand Jha needs no introduction. In fact, he is known to everybody, from the oldest to the youngest in nephrology throughout the world. And he has reached where nobody so far has reached from Indian nephrology. He is the executive director of George Institute for Global Health, India. He is the chair of Global Kidney Health. He is the Faculty of Medicine at Imperial College of London. And above all, he is the president of International Society of Nephrology. And we are all proud that he is one of the alumnus from PGI Chandigarh. And in addition, he has not left his clinical touch. He is still working as a senior consultant nephrologist at one of the main hospital in Delhi. And he has more than 250 publications, both in national as well as international journals. And he is involved in various global clinical trials. This topic is very close to his heart, and he has done a lot of original work also on IgA nephropathy. He will be delivering his talk on current knowledge and management of IgA nephropathy. Professor Jha, please.
Thanks a lot, Professor Bhalla. Can you hear me?
Yes, sir. Yes, sir.
And you can see my screen, I hope.
Yes, yes.
Great. Thank you, Dr. Bhalla, once again for your very kind introductions. You are always very kind as my senior and, of course, a good friend now. I would like to thank Professor K.L. Gupta and Professor Narayan Prasad, the President and the Secretary General, respectively, of the Indian Society of Nephrology for asking me to come and speak with you this afternoon and evening now. And I would first of all like to congratulate Manisha and Santosh for conducting a fantastic quiz. All the questions were very good and probing, conducted in real time with good timekeeping, and I'm sure that the participants enjoyed answering those questions. So I'm going to talk about IgA nephropathy, of course, which is of interest to me, but also to a number of other people on around this Zoom call. And I'm rather than talking about advances, etc., I'm calling it a primer of IgA nephropathy, because while preparing for this talk, I also learned quite a lot, and I hope you will too as well. Just for the background, I think we all agree that IgA nephropathy is commonly taken to be the most frequently encountered glomerulonephritis worldwide. It has a heterogeneous presentation and course. We know that there are a few progression factors which determine which patient will do well and who will not. The pathogenesis, so far as we know, supports plausibility for use of immunosuppressive therapy, but the benefits and risk of this type of immunosuppressive treatments are uncertain based on clinical trials so far. The main questions that we all have to grapple with as clinicians are when to intervene in these subjects, what regime should we use, and with what expected benefits and risks. Sadly, to the last three questions, we know very little, and that's a big knowledge gap which we must do everything that we have in our power to overcome. Going back to the history, because this is something which I learned during my training days in PGI, is that whenever you talk about the disease, you must know how it all started. So the disease, for those who are old timers, was earlier called Berger's disease because it was described for the first time by two pathologists, Jean Berger, whose picture you see on the left, and the second person was Nicole Ingley, a lady electron microscopist. Unfortunately, despite trying high and low, I was unable to find a picture of Nicole anywhere on the web, which is a shame because women scientists do not receive as much prominence as male scientists do. Also, actually evidenced by the fact that the disease was named after Berger, who was the male partner in this pair. Okay, so what we all know at this time is that IgA nephropathy is actually diagnosed on kidney biopsy. That's a fact, right? We don't have any clinical criteria for making a good diagnosis of IgA nephropathy. We don't have any biomarkers. And over the course of last about 10 or 15 years, there has been a lot of progress in understanding the histopathology of IgA nephropathy, which led to development of this MEST or Oxford classification, which was later supplemented by the letter C, which talked about crescent. So I'm sure you all know by now that MEST indicates mesangial hypercellularity, endocapillary hypercellularity, segmental sclerosis, and the T stands for tubular atrophy and interstitial fibrosis. And all of these five criteria receive a score of, in most cases, 0 and 1, and in the case of tubular atrophy and crescents, 0, 1, and 2. So what does it look like if you use the MEST score? So this is a panel of photomicrographs. I know that Dr. Sanjeev Sethi is online, and he would perhaps be the best person to explain this. But the point to make here is, from the picture on the top left, is that you may have a completely normal looking glomerulus in IgA nephropathy as well. So this is a glomerulus with a MESTC of all scores of 0. But if you do immunofluorescence, you will find IgA in this. The second one shows some degree of mesangial hypercellularity on the top, indicated here by the black arrow. The third photograph on the top panel shows you both mesangial cellularity, hypercellularity, and also endocapillary hypercellularity. You can see that the capillary lumen is compromised and there is an inflammatory cell inside the lumen. On the bottom left photograph in this panel, you can see an area of segmental sclerosis in the glomerulus. All the other parameters do not indicate any abnormality. In the middle picture, you see a lot of by Masson's trichrome stain here. You see a fair amount of tubular atrophy. So this biopsy received a score of T2. And on the bottom right side, you can see a crescent actually in this specific glomerulus. And this slide was assigned a score of C1. Immunofluorescence is critical to the diagnosis of IgA nephropathy. And of the two IgA subtypes, IgA1 and IgA2, IgA1 is the one that is found predominantly in this. IgG and IgM can also be positive in this, but IgA1 is the dominant or co-dominant deposit. C1q is typically absent, indicating that the classical pathway of complement is not activated. However, C3 is positive in 90% of cases, indicating that there is activation of either alternate pathway or mannose binding lectin pathway. You can see IgA positivity in the casts as well. So, and between the two light chains, you see more intense staining with, although both the light chains do show up, but lambda light chain is generally more prominent than kappa light chain. On electron microscopy, here you can see indicated by the red arrow is the basement membrane, and by the blue arrow you can see the paramesangial area, and the black arrows indicate the presence of electron dense deposits in the paramesangial area and the mesangial area, which is typical of IgA nephropathy. Let's look at the clinical presentation, and this is data from Dr. Susina Alexander at Christian Medical College, Vellore, where she has a large cohort of more than 200 subjects of IgA nephropathy. I'm sure it has become bigger now. And you can see that the mean age of presentation in her cohort was about 36 years. And you can see that 84% of the patients had hypertension. Only about 4% had synpharyngeal illness prior to presentation. So although that is typically described as a classical presentation, we see it very uncommonly in our subjects. And you can see that pedal edema was present in about 46 subjects. Visible hematuria was present in about 10% of subjects, whereas microscopic hematuria was present in about 73%. So 73 plus 10, 83% of patients had either gross or microscopic hematuria. Family history was present in just about 6% of these patients before presentation. This is important because familial clustering is thought to be an important predisposing factor for IgA nephropathy. In this paper, Dr. Alexander described the presence of these various abnormalities on the basis of the degree of urine protein excretion, less than 1 gram, 1 to 2.99 grams, and more than 2.99 grams in the three clusters from top to bottom, and divided from left to right on the basis of CKD epi EGFR less than 30, 30 to 60, and more than 60. And as you can see, that as the proteinuria increases and as the GFR decreases, the number of abnormalities and number of patients with multiple abnormalities increases. And these abnormalities are hypertension, pedal edema, systemic symptoms, macroscopic hematuria, etc. Okay, so that's as much about the clinical symptoms. Now there are two other histological lesions which can cause the presentation with acute kidney injury in these individuals. One is, of course, the presence of presentic glomerulonephritis, and presents are defined as presentic GN is defined when there are more than 50% presents. And the second instance when there could be acute kidney injury is when a patient develops macroscopic hematuria and there is tubular obstruction due to red blood cell casts, and there is also tubular injury because of the passage of red blood cell itself. Now, it's very important to differentiate between the two because for the first one, you will need to treat aggressively with immunosuppressive therapy But for the second one, you just need to wait it out. Most of these patients will recover, although about 25% might be left with some degree of residual kidney dysfunction, even if the histological lesion does not show any presence of any T cells. One advance that has been made over the last few years is the development of a risk prediction tool in IgA nephropathy. So there is this group of researchers on IgA nephropathy that is constantly working together. Those were the people who initially developed the Oxford MEST classification. And then using data from the MEST classification and clinical features, Dr. Sean Barbour and colleagues around the world came up with this risk prediction tool. And I would encourage you all to actually go to this website, and you can download this tool both for your iPhone and for your Android phone. It takes about 13 features and gives you a risk score. And these 13 features are listed on the left. And what does it tell you? In the end of it, once you have entered the values for all of these 13, it gives you an individualized risk of a 50% reduction in EGFR or development of end-stage kidney failure over a period of about 5 years following the kidney biopsy. Now, it's important to note that the IgA nephropathy risk score does not tell you anything about the likelihood of response to treatment. That's important. And that's something which actually the question that was put to you in the initial part of this session got a little wrong because it said it can tell you about treatment response. It does not tell you anything about the treatment response at all. It simply tells you the risk for development of kidney failure. Why so? Because the risk for development of kidney failure can be heightened simply because there is tubular atrophy and there is segmental sclerosis. And those lesions are not likely to respond to treatment at all. So please just keep that in mind. Despite the fact that there is intense research going on for biomarkers, the research for biomarkers has proven elusive so far. This is data from the STOP IgA cohort, and what they showed is that when they looked at these 4 biomarkers, NGAL, KIM1, calprotectin, and TIMP2 IGFP B7, when they evaluated the performance of these by these ROC curves against either full clinical remission or decline of EGFR to less than 15, they found that they were no better than by chance. You can see that it's really very close to the diagonal line, which is a line that indicates presence by chance. So we continue to look for biomarkers. Now, do know that there is significant geographic difference in the prevalence of IgA nephropathy. Can you stop, Dr. Gupta? There is significant geographic differences in the prevalence of IgA nephropathy in kidney biopsies around the world, with East Asian and North Asian countries showing as high as 40 to 50% prevalence of IgA nephropathy in their biopsy series, whereas reports from Sub-Saharan Africa describe IgA nephropathy in just about 1% of all their biopsies, and North Africa about 5%. Similarly, Latin America about 5 to 6% only. However, Dr. John Barrett and his colleagues showed that the frequency with which you encounter IgA nephropathy in kidney biopsies is directly related to the frequency with which you do the kidney biopsy. So if you do more kidney biopsy, you will find more IgA nephropathy. And the other thing which is worth remembering is the concept of lead time bias, which depends. So what is lead time bias? Lead time bias is a situation where you see a patient only when the patient presents to you, and you don't know what happened to the patient before they came to you. For example, often it is described that IgA nephropathy patients in India present with either declining GFR or more advanced lesion on the kidney biopsy. Now, it is possible the patient just did not present before that particular point of time, and so it presents us with a lead time bias, and that is consistent with the concept of subclinical or so-called lanthannic IgA nephropathy. So you can have these hypothetical patients shown on this curve who might present either when the GFR is normal and at this time, even after the disease has progressed for quite some time, there has been proteinuria or microscopic hematuria, but the GFR still remains normal. But if the patient presents still later, then of course the GFR has started falling, and in some cases, you may encounter the patient for the first time when even kidney replacement therapy has started. So this takes me back to the old saying by Dr. Thomas Addis, who said that the examination of the urine is the most essential part of physical examination of any patient. Because only if you examine the urine, you will find microscopic hematuria, which is likely to be the most common finding in a patient with IgA nephropathy. We do know that such kind of routine screening is very common in countries like Japan, where even at the time of entering school children undergo routine microscopy of their urines, and abnormalities are found and they are biopsied, and that is one reason you find a lot of patients with IgA nephropathy. Now, coming to the pathogenesis of IgA nephropathy, it's very important to point out that IgA nephropathy is actually a systemic disease in which the kidneys are injured as innocent bystanders. We know this because of two factors, both related to kidney transplantation. One, that if a patient with IgA nephropathy receives a kidney transplant, which is obviously from a donor who does not have IgA nephropathy can recur in the donor kidney, which means that it was present in the systemic circulation of the recipient and it came back into the transplanted kidney. And second, it has also been shown that just by chance, sometimes donor kidneys, when they have been retrieved, they have been found to contain IgA in the 0-hour biopsy. And it has been shown that in subsequent biopsies in the recipient, those IgA deposits have disappeared. So that's important. Now, let me spend a minute or two on explaining to you the pathogenesis of IgA nephropathy, which has everything to do with the structure of the IgA molecule. So as we know, like all immunoglobulin molecules, the IgA molecule is a monomer, which was a question which was asked to you again in the quiz. So the monomer has a heavy chain and has a light chain, and the heavy chain has the Fc fragment and the Fab fragment, and between the two you have this so-called the hinge region. The hinge region it consists of a number of proteins, and you have two important proteins which are highlighted in red here, serine and threonine. These serine and threonine have an oxygen molecule, and this oxygen molecule links to a galactose molecule, right? So it's so it's called O-linked glycans. And so you have the GalNAc, and then you have sialic acid, and then you have the galactose. So there are three molecules here, okay? So you can see the sequence here. So if the GalNAc is there, and then if galactose comes, then you can still have the sialic acid coming in. But if sialic acid comes first, then it does not allow galactose to join here, okay? So these are the 5 situations that you might encounter. And it is this situation where you have sialic acid and no galactosamine. So that is the type of IgA1 that is responsible for development of IgA nephropathy lesions. And the IgA nephropathy lesion sequence of events is shown in this particular cartoon, that because of either a genetic presence of genetic background or because of some infection, bacteria, etc. in the gut and so on, we don't know enough. There is activation of this cascade in which the key players are BAFF and APRIL, which act on the naive B cell and convert it into plasma cell. And the plasma cell leads to elaboration of this IgA, and the IgA monomers become dimers, and these are galactose deficient. So the first thing that happens is the increase in level of galactose deficient IgA1. Okay, so this is called GD minus IgA1. Okay, so this GD minus IgA1 leads to generation of IgG molecules against these galactose deficient IgA1. If the IgA1 molecule is not galactose deficient, IgG molecule will not be produced against it. Now, once these IgG molecules are produced, they actually combine with the galactose deficient IgA1, and there is formation of immune complex, which is the third hit. And this immune complex, IgG, IgA1, galactose deficient immune complex, has particular affinity to the renal mesangium, and it goes and deposits itself in the renal mesangium, which leads to renal injury, which is the fourth hit in this series. Okay, so what are the other changes that we see in IgA nephropathy? Two changes I would highlight. One is podocytopathy, and second is microangiopathy. So podocytopathy is when the mesangial inflammation leads to focal loss of podocytes. So there is no primary injury in the podocyte, but it is secondary to the mesangial loss. And this leads to podocyturia. And once there is podocyturia, there is denudation of the basement membrane, and there is further changes which causes podocytopathy. The other thing also that happens is microangiopathy. So there is change in microvasculature because, as you know, the abnormal immune complexes are first trapped in the microvasculature, and so there is a high incidence of hypertension and other changes in the vessels, which also contribute to development of further lesions here. And as you might imagine, complement is important. Why this is important? Because it's become a very, very important therapeutic target now. I won't go into the detail, but please note that the classical pathway is not activated. It is the lectin pathway and the alternative pathway proteins which are increased or altered in the presence of progressive IgA nephropathy. So now let me turn to the treatment of IgA nephropathy. And just like Dr. Radhakrishnan, I'm going to present to you some statements which are going to appear in the 2021 KDIGO guidelines. So what the guideline is going to say that the primary focus of management should be optimized supportive care. Please note, the primary focus of management is not immunosuppressive therapy, but optimized supportive care, which includes assessment of cardiovascular risk and appropriate interventions, lifestyle advice, dietary sodium, and we'll talk a little bit more about it later. And other than dietary sodium restriction, no specific dietary intervention has been shown to alter outcomes in IgA nephropathy. So please don't start advising very low protein diet and so on and so forth. Then there are a few variant forms of IgA nephropathy, which associated with minimal change disease, acute kidney injury, and RPGN, which might require specific treatment. Also, reiterating the point that there is no evidence right now to support the use of Oxford classification in determining whether immunosuppression should be commenced in IgA nephropathy. So it's still determined the decision to start immunosuppression is mainly clinical based on proteinuria and EGFR. And also, the presence and number of crescents do not help you in making treatment decisions unless there is rapidly progressive glomerulonephritis more than 50% crescents. And also, as I said before, the IgA nephropathy prediction tool cannot be used to determine the likely impact of any particular treatment regime. So how are you going to assess and manage patients with IgA nephropathy? So first of all, you consider secondary causes, which include IgA vasculitis, infections, other autoimmune diseases. Once you have excluded all of that, which include IgA dominant infection-related GN as well, then you come to a diagnosis of idiopathic IgA nephropathy, and then you go ahead and score the kidney biopsy using the MEST-C score. And then you, of course, will risk stratify the patient. And then ideally, you should enroll the patient in a disease registry. That's something which is going to be a theme here. And comments, as I said before, optimize supportive care. What is the supportive care? Diet modification, only salt restriction, weight optimization, because obesity has been associated with poor prognosis and weight loss is beneficial. There is RCT evidence to suggest that. Smoking cessation, very important. There are cohort studies and case control studies. Renin-angiotensin system blockade is the first line management in IgA nephropathy. It's been shown to be beneficial in several randomized controlled trials and meta-analysis. It's been corroborated in the STOP IgA nephropathy trial as well. And please note that dual blockade is controversial. So at this time, please don't attempt those. Tonsillectomy has been shown to work only in Japanese patients, but elsewhere it has not been shown to be any benefit. So now you will obviously ask the question, how about patients who are at risk of progressive chronic kidney disease despite maximal supportive care? So that is where you might consider immunosuppressive therapy, but please note that benefit of steroids in a testing study was found only in people who had on an average of 2.5 grams of proteinuria. So lower than that, the benefit of steroids is questionable, okay? And in view of current uncertainty over the safety and efficacy of current immunosuppressive treatment, the KDIGO guideline is going to say that all patients should be offered the opportunity to take part in a clinical trial. So don't go ahead and just start treating a patient. To the extent possible, make sure that you give your patient the opportunity to participate in a clinical trial. So this is the summary algorithm of the same point. Proteinuria more than 1 gram for 3 months, maximally tolerated dose of ACE inhibitors, lifestyle modification, cardiovascular disease. Once again, reiterating the point, consider enrollment in a clinical trial, or if the GFR is still over 30, perform a toxicity risk stratification. Why there is so much emphasis? Because 2 large studies, the STOP IgA and testing trial, did show the high likelihood of adverse events. And if the risk-benefit profile favors, only then you should discuss the use of corticosteroids in these populations. Now, a large number of currently drugs are under investigation for treatment of IgA nephropathy, and these therapeutic molecules are targeting specific pathogenic mechanisms, starting from hydroxychloroquine, which targets the toll-like receptor, which is part of the innate immunity, bortezomib, which targets the proteasome, which is present in the plasma cells, and then you have budesonide, which targets the mucosal-associated lymphoid tissue, because that is a putative site for origin of the galactose-deficient IgA1 molecule. And then you have, based on the pathogenesis, you have molecules which act against BAFF, which act against abatacept, and a number of molecules, as I said, which are acting against complement, starting from the top, anti-C5 to C5 receptor blockers, C3 inhibitor, factor B inhibitor, MASP inhibitor. But also there are other molecules which act at the level of inflammation. And of course, you have the renin-angiotensin system. This is basically the same thing. And this is a list. Again, I don't expect you to be able to read this slide, but just to make the point that there are a large number of clinical trials which are currently underway. You can go to this particular publication by Dr. Vladimir Tesar and colleague, and you can find details of all of these clinical trials. Many of these clinical trials are running in India as well. The VIS anti-APRIL molecule, ALIGN trial, which is a trial of sparsentan, etc. So please look for those trials and give your patients the opportunity to enroll in those trials. I'm aware that I did not talk about a number of things in IgA nephropathy. I did not talk about IgA nephropathy. Vasculitis, I did not talk about IgA nephropathy in children. I also did not talk about genetics. I did not talk about IgA nephropathy after transplantation. And also, I would like to reemphasize that there are still a lot of knowledge gaps about risk stratification, evaluation of therapeutic strategies that minimize or avoid systemic corticosteroid exposure. These are the molecules which are currently in clinical trials. We also need to do more about development of biomarkers and to understand more fundamental biology, especially genetic and environmental factors. These factors need to be particularly understood in India because the genetics is likely to be different. So in summary, IgA nephropathy is likely the most common primary glomerular disease in the world. It disproportionately affects children and young adults. It presents with hematuria or proteinuria. A subset will develop progressive decline in kidney function. It is a systemic autoimmune disease due to circulating immune complexes comprised of galactose-deficient IgA1 bound to immunoglobulin. Currently, there is no disease-specific treatment, and there are new disease-targeted therapies that are being evaluated. And I would encourage you to contribute to knowledge by enrolling patients in clinical trials. I'm going to stop here. And once again, my thanks to the organizers as well as to you for patient listening. And I'm happy to answer any question if you have.
Thank you, Professor Jha, for excellent presentation. In such a short time, you have covered practically the whole of the topic. And in fact, Dr. Jha is himself involved in various clinical trials on IgA nephropathy treatment. And there are a few questions in the chat box. One is by, I think, Professor Sanjeev Sethi. Why don't we see IgG on biopsy of IgA nephropathy patients when the complexes are of IgG and IgA1?
I am really afraid of putting my foot into my mouth when Sanjeev is around. So why don't you explain that to us, Sanjeev?
I have no idea. I always have thought of it. They say it's the IgG complex with IgA1, and I've always wondered why there's never any IgG. If it's 1:1, why don't we see IgG? I have no idea.
So one explanation could be I'm not sure it is 1:1 when there are what IgG does is to actually promote the development of immune complexes. in which there might be more than one molecule of IgA1 with each molecule of IgG. That's my speculation, and that might be responsible for IgG being less prominent than IgA1. But of course, that's just a speculation. I don't know the right answer here.
And another question is, Dr. Jha, what is the role of urine proteomic IgA 237 for diagnosis?
Yeah, well, there is no role of, I mean, all these studies are ongoing, but we need to know much more. As I showed, at least I just showed one paper, but there are many other papers which have tried to study various biomarkers. And right now, all these studies are going on, and we need to know more before we are able to give any conclusive answer.
Okay. And one more question, any difference in using immunosuppressive agents between IgA vasculitis and IgA nephropathy?
Yeah, so there is, as Rajiv Sinha has asked this question, as Rajiv knows well, and as I try to emphasize, the evidence base in IgA nephropathy or IgA vasculitis is very weak. It is weak in IgA nephropathy, and it is practically non-existent in IgA vasculitis. So we don't have any evidence-based knowledge of any difference in using immunosuppression. And currently, the recommendations remain use of immunosuppression just using the criteria that you have for IgA nephropathy.
Yes, then Dr. Anuradha has asked question, patients presenting with accelerated hypertension, your comments on that, because in fact, that is our experience that most of the patients present to us with relatively higher creatinine, maybe more than 2.5 or 3, and accelerated hypertension is one of the presentation in our patients, especially in Indian patients.
Yeah, that's right. So accelerated hypertension is classically described as one of the presenting features of IgA nephropathy for more than 30 years, since the time we were students. And as I said before, this could be related to the microangiopathic lesions associated with IgA nephropathy, because the immune complexes first circulate in the microvasculature before they get deposited into the mesangium. And when they are in the microvasculature, they obviously interact with the endothelium and produce endothelial injury, which could be potentially related to higher incidence of hypertension. You saw from the data that I presented from Dr. Susina Alexander is that as the proteinuria increases and as the GFR decreases, the likelihood of the patient having hypertension at presentation go up.
And the last question is by Dr. Harshvardhan. One is this budesonide. How much is the dose?
So budesonide is right now in clinical trials. And so once the clinical trial results are out, then we will know what dose works. So at this point, there is no evidence to suggest, I mean, we need to basically wait to see what dose works in budesonide in the clinical trial. Phase 2 trial was quite promising, and in phase 2, they tried 2 doses of budesonide, 8 and 16 milligrams. So let's just wait for the results of the phase 3 study.
And how often you see low complements in IgA nephropathy?
You don't see low complements in IgA nephropathy. So there is a local complement activation, but the systemic complement levels don't go down in IgA nephropathy.
Okay. And what is the role of omega-3 fatty acids? As you know, that is a standard practice. A lot of, in fact, nephrologists, they use omega-3 fatty acids, fish oil.
Yeah, so those were, again, this is a historical legacy that we continue to stick with, because we don't have anything better to offer. So that just indicates that we have made very little progress, and we are sticking to a particular treatment regime, which is also very weak. There is no evidence to suggest at all that omega-3 fatty acid gives any positive results in patients with IgA nephropathy. So at this time, there is no role of omega-3 fatty acids.
Thank you, Dr. Jha, for excellent question answer session and excellent coverage of this very important topic, very common topic. Now I move on to the next. I invite Professor Sanjay Agarwal to invite the next speaker. Professor Sanjay Agarwal is the head of Department of Nephrology at All India Institute of Medical Sciences. He is the editor of Indian Society of Indian Journal of Nephrology, and he has vast experience in and a lot of publications. Professor Sanjay, please.
Dr. Agarwal sir, you have to unmute.
Sorry, Sanjeev doesn't need introduction to Indian audience, but for a customary, he is currently a professor at Mayo Clinic, Rochester. He graduated from Assam Medical College, India. He did graduate study in Albany Medical College, New York. Did his PhD in experimental pathology, and then he did his pathology residency at Yale University and fellowship in the renal pathology at Brigham and Women's Hospital, Harvard University. We all know that he has a very special interest in approach to glomerulonephritis and its classification. Plus, he has got further interest in monoclonal gammopathy, alternate complement in glomerulonephritis, proteomics in renal pathology, and a novel approach to glomerular disease. With that background, he has got more than 230 peer-reviewed publication. Sanjeev, all to you.
Thank you. Can you hear me?
Yeah.
Yes.
This is the first time I'm doing this thing from home, so because of the timing. Usually it's always at work. So thank you very much for the invitation. Dr. Agarwal, I'm honored to be in this with all the nephrologists. I think I'm the only pathologist here, so it's an honor to present. Can you see my screen, or I opened it?
Yeah, just share, sir.
Okay, I'm doing it now.
Yeah.
Is that okay?
Yeah, you are audible. Just
okay. So, this talk I just gave a grand rounds on this a few months ago. It's a 1 hour talk, but I'm trying to do this in 30 minutes. So we'll try and do the best we can. There's a lot of pathology involved, number one. Number two, I will really stick to the concepts, how this whole story came about 10 years ago. So that's the title of my talk, Understanding MPGN, and of course, C3G is part of the MPGN story. There's nothing here as a pathologist. So the overview really is what is MPGN and where does C3G fit in, and the whole story. Let me just make this screen because I am, okay, doesn't matter. So, and then I'll talk about the pathology of C3G. I don't think I will have time to go into the mass spectrometry material with MPGN and C3G today, but in any case, it's part of the talk. So first of all, what is MPGN? I need to take this off just 1 minute, okay? Yeah, now I'm okay because it was showing everybody's face. Okay, so what is MPGN? For me, there are two parts of MPGN. One is there's an active phase and then there's a chronic phase. So when you have both activity and chronicity is when the picture looks like MPGN. So the chronic part of MPGN is when there is deposition of, I like to call it debris, usually immunoglobulins, complement, fibrin. So when you keep on having this material deposited in the glomerular capillary walls over a long period of time, it leads to MPGN. Initially, it starts with an inflammatory phase. That means you see lots of cells, both in the mesangium and in the capillary lumen, trying to clean up the deposition of this material. This is then followed by a chronic phase where if the clinician has been good in treating or if the lesion somewhat subsides, and then you get this remodeling of the capillary walls. So there is an inflammatory phase and there's a remodeling phase. When you have both of them together, then you get an MPGN. If you have only inflammation, then it's more like a diffuse proliferative lesion, but you need the resolving phase for it to be called MPGN. So let's take a look at this. 1 second. Okay, and I'll talk about it in a little bit. So that's what I was just saying. On pathology, you need the proliferative phase, that's inflammation. You can get mesangial and endocapillary hypercellularity. But with time, over time, what happens is there's a resolving phase where the deposits and the debris are removed by the inflammatory cells. And what is left behind are these thickened capillary walls along with mesangial expansion. And that's called the membrano or the membranous phase of MPGN. So that's the light microscopy, and I will show you some pictures, so don't worry. On immunofluorescence microscopy, if you look at the old textbooks, the standard textbooks, they will always say It is characterized by the presence of immunoglobulins, both kappa or lambda light chains, or one of the two, and very often there is C3. So the immunofluorescence was a neglected part of MPGN, basically saying that there are immunoglobulins or they may or may not be C3. Then came the electron microscopy, which clearly show the deposits. They are present both in the mesangium and along the capillary walls. The deposits is where, for whatever reason, was where the focus in classifying MPGN was for a long time. Okay, and we'll get into that a little bit. So this is what the MPGN looks like. If you look at the bottom, this is the normal glomerulus, and on the top is what the MPGN looks like. As you can see over here, there's mesangial expansion with lots of cells or proliferative features. If you look over here, this is the capillary wall that is very thick. There's a double contour over there. And so this is the chronic phase. Over here, you see lots of cells in the capillary lumen, over here as well. So this is the active phase. So this is the active phase along with the double contour. And then all of this makes it a very like a lobular accentuation. So this is what's called the MPGN or the MPGN pattern. Okay, bottom line is there's inflammation, number one. Number two, there is healing at the same time. This was just pure proliferative, then it would be a diffuse proliferative. It would not be MPGN. There's no healing there. So this is what the lesion on electron microscopy looks like during the active phase. As you can see over here, you cannot tell much, okay? This is the old basement membrane. These are all deposits, electron dense deposits. And then there is a new basement membrane over here. So this is the double contour, but there's lots of cells in here. Okay, so this is really the active phase. That means you have deposits and you have the inflammation and the entire lumen is filled with cells. And this is the endocapillary hypercellularity. So the active phase. But as the lesion progresses and maybe the clinician is good in treating that cause of the MPGN, then healing occurs. When healing occurs, you can see that it becomes more chronic over here. Now what you have is a big double contour. That's the original basement membrane. And cells and immune deposits are trapped between this new basement membrane and you get a double contour. And see over here, even a neutrophil, I think, is entrapped. The idea of this double contour is protecting the glomerular capillary walls from the invading neutrophils or the mononuclear cells. What happens is these deposits are then sort of put away by the basement membrane, and as a result, there are no neutrophils or monocytes, and as a result, the inflammation somewhat goes down. So that's the whole idea. So there's proliferation and then there's healing. Keep in mind that even though this looks a very thick GBM or capillary wall, this is not a perfect capillary wall, and this can be quite, can leak a lot of red blood cells and protein particularly. And that's why when the MPGN, the way I like to think of it is initially when the injury occurs for whatever reason, it looks very proliferative. And the clinical scenario is that the patient almost always presents with a nephritic picture. Okay, so that means he's got acute renal failure, lots of red blood cells in the urine, and so on. As the lesion progresses, it goes from diffuse proliferative to classic MPGN over here. And now the capillary walls are thickened, they become leaking, and you get a nephrotic. And as the lesion becomes chronic, the cellularity decreases, but the double contours are very well formed. And now the changes to more nephrotic because the inflammation is much less at this time. So this is the typical scenario of how the lesions progress from diffuse proliferative to chronic lesions. Now, like I said, the focus for the longest time for MPGN was how do we classify it? And in fact, it upsets me sometimes. And even the day before yesterday, I saw a case that was called MPGN type 1. And all that was done is when you do electron microscopy, depending upon where you saw the deposits, you classified MPGN into type 1. If the deposits were purely subendothelial, like over here, and on the other hand, if the deposits were intramembranous, then we called it dense deposit disease. And finally, if along with some subendothelial deposits, you saw a few subepithelial deposits, you called it type 3. Keep in mind that the type 1 and type 3 had nothing to do with the underlying etiology. It was purely an ultrastructural examination of the deposits, and then you made the classification, had zero basis for the underlying etiology. So this would be 1 because you see the subendothelial deposits. This would be 2 2 we know is dense deposit disease and is alternative pathway. We'll talk about this later. And number 3 is when you see, along with the subendothelial, you see the subepithelial deposit. So this would be a type 3. Okay. This was the classification that was used for a very long time. Subsequently, in the 1990s, it was noticed that many of these patients of MPGN were due to, or patients had history of hepatitis. Excuse me. So at that time, what they did was they came up with the classification. Actually, it was Dr. Renke who came up with the classification of primary and secondary MPGN. In most cases, wherever you had hepatitis or there was a history of active hepatitis, we called it secondary MPGN, and all the others were fit into primary MPGN. Again, with primary meaning there's no underlying disease association. We didn't know what the cause was. Secondary, by and large, a large number were fitting in with the hepatitis story. Now, I'm going to give you 4 examples to show you that almost in every case of MPGN, you can come up with an underlying etiology. So this whole classification of primary and secondary, or 1, 2, 3, is really old, and we really need to, we can actually come up with an etiology in every class of, every case of MPGN, as long as we pay some attention to the biopsy findings. So let's go through 4 cases. The first one is a 47-year-old man with proteinuria, hematuria, and renal failure. Serum creatinine is 4.7. His creatinine clearance is only 14. He has red blood cells, so he has a nephritic syndrome, and he has low complement titers. Okay. Very often in MPGN, you will see low complement titers because even if it is immune complex or complement, the complement is being activated, so you get low complement titers. Here's the classic MPGN. You can see this lobular accentuation. You can see increased cellularity. If you look carefully, even at this power, you can see the double contours. You can see the lobular look. In fact, in this one also, you can see some Highland type immune microthrombi in this case. And if you look at the immunofluorescence, this is important. It was characterized by bright IgM, bright C3, bright lambda, and bright kappa. So he has IgM, kappa, lambda, and C3. Electron microscopy shows you the classic subendothelial electron dense deposits over here. No subepithelial deposits, okay? And this is the double contour. Let's look at patient number 2. This is a 66-year-old man with hypertension, nephrotic range proteinuria. Again, he has 6 grams of protein. Again, lots of red blood cells. So again, he has a nephrotic and nephritic picture. Again, like the previous case, low C3 and low C4 levels. In this particular case, same story, has an MPGN look, very high cellularity over here. Okay, and this is just to show you the double contour formation. Again, classic MPGN on light microscopy. In this case, however, when you do the immunofluorescence, this also has IgM, C3, but instead of both kappa and lambda, this is only IgM kappa. Okay, so you have bright IgM kappa with no lambda light chains. When you do the electron microscopy in this particular case, again, only subendothelial electron dense deposits, no subepithelial deposits, okay? You can see the subendothelial deposits even over here, low power. Third case, this is a young girl from, I always say, neighboring state of Wisconsin. Again, she has a proliferative lesion, and this was detected because she had hematuria and proteinuria. This was detected during an annual exam for, I think she was during the basketball team. But anyway, this also shows you the MPGN, and you can see over here, you can see some endocapillary hypercellularity, quite thickened capillary walls. You can see over here. And on immunofluorescence, it was bright C3, but everything else was negative, IgA, IgG, IgM, kappa, and lambda. And you can see in this case, there are extremely dense deposits along the capillary walls. Mostly all of them are intramembranous. And this is the last case. This is a 61-year-old man with monoclonal gammopathy, small little spike of only 0.5 to 0.9. Again, low C3, in this case, normal C4, hematuria. So again, he has nephritic picture. In this case, because of the monoclonal gammopathy, he had a bone marrow biopsy done that shows 8% plasma cells. In those days, we call this MGUS. Now, I guess this would be characterized as MGRS, but from the hematologic standpoint, it's still an MGUS. He was biopsied twice, 2007 and 2009, because he kept being called post-infectious glomerulonephritis, even though he had no infection whatsoever. Here again, his biopsy shows you the MPGN. You can see the lobular accentuation. You can see the double contours. You can see the mesangial hypercellularity. You can see quite a bit of endocapillary hypercellularity as well. In this patient too, just like the previous case, he had only C3. Okay, again, IgA, IgG, IgM, C1q, kappa lambda, everything negative. But instead of the dense deposits, he had these large accumulation of these globular deposits. You can see in the mesangium. You can also see here in the capillary walls. But the key finding here was he had lots of subepithelial hump-like deposits. Because of these hump-like deposits, he was labeled many times as a post-infectious or infection-related glomerulonephritis. Okay, so now you have 4 cases. This is the first one, this is the second one, this is the third one, and this is the fourth one. All of them show you MPGN like pictures on light microscopy, okay? However, on EM, this is the first one, subendothelial deposits. Second case, subendothelial deposits. Third case, intramembranous deposits. And fourth case, along with the subendothelial deposits, he also has a subepithelial deposit, okay? So if you went by the classification, by the conventional classification, you would classify 1 and 2 as MPGN type 1. Case number 3, you would classify as MPGN type 2 because intramembranous. And case number 4, the last one, you would classify as subendothelial and subepithelial. So you would classify it as MPGN type 3. But if you look carefully, okay, and keep in mind, this would give you no idea of the underlying etiology of either of the cases, except for perhaps case 3. But 1, 2, and 4, you would have no idea. Even if you went with primary and secondary, you would probably not be able to come up with an etiology in most of these cases. But when you look at the biopsy, you can clearly see on immunofluorescence microscopy, case number 1 and 2, one had IgM, kappa, and lambda. Patient number 2 had IgM, kappa only, and patients number 3 and 4 had complement deposits only. So you can clearly see that there are 2 groups over here. Not very difficult to tell them apart. And so I many years ago thought an easy way to make the classification of MPGN was the presence of complement alone or presence of complement with immune deposits. And once you did this, you could come up with an etiology in almost all cases of MPGN. So patient number 1 was immune complex with polyclonal IgM. So whenever you see IgM that's polyclonal, think of a viral infection. That's very typical. So whether it is hepatitis or any other viral infection, you will get IgM. If it's a bacterial infection, like a shunt endocarditis or any chronic bacterial infection, you will get more IgG than IgM. But clearly you can tell that this is an MPGN from immune complex. A polyclonal disease most likely is associated with an infection. The second patient also had immune deposits, but it was restricted to IgM kappa, okay? And in this patient, we can clearly tell this is an MPGN from monoclonal immunoglobulins. Workup on this patient showed CLL. PGN-MID, that's well described now, also falls in this particular group. It's associated with monoclonal IgG deposits, very often is IgG3. So this would be the immune complex type. The third one patient was, of course, we know now, he has intramembranous deposits, and this is related to alternative pathway complement. And the fourth patient, in those days, I called it complement mediated. We did not have the terminology of C3GN yet. So I remember was wondering what to call it. And I suggested complement mediated because there was no immunoglobulins. And so we called it, now we know this is C3GN. So the classification of, so this is what, this I already told you. So the classification of MPGN, what I came up with this is in 2007, I think is when I came up with this, was let's look at MPGN like this. You have a proliferative GN with both active and chronic phases. When you have immunoglobulins, I like to call it immune complex or immunoglobulin mediated. And typically, immune complexes come from three things. One, like I showed you, maybe in India it's more common, infections. IgG means bacterial, IgM means it's viral. Dysproteinemias, which is very common where I live at the Mayo Clinic. That means you will see IgG or IgM, which is kappa or lambda restricted. Sometimes you'll only see kappa or lambda. You don't even see the heavy chain. And the third is autoimmune disease. I didn't give you an example because of shortage of time. So patients with lupus, patients with Sjogren's and any other autoimmune disease can also give rise to immune complex disease. Looking at the immune complexes, you can tell one from the other. Like I said, infections is usually IgM or IgG and is polyclonal. Dysproteinemia is always limited to, there's light chain restriction, so it's quite easy to tell. Autoimmune disease very often shows you, as you all know, multiple immunoglobulins. So you can get IgA, IgG, IgM, very often the C1q as well. And so this would categorize as the immune complex sort of GN. On the other hand, if you only saw complement and you did not see any immunoglobulins, or you saw very small amounts of immunoglobulins, then we label these as complement-mediated GNs at that time, but now we call this C3G. And this occurs from the dysregulation of the alternative pathway of complement. And this can further be divided into dense deposit disease and C3GN. Again, this is an old slide from this manuscript. I wrote this in 2007. Nobody wanted to believe it at that time. And then, of course, now it's accepted classification of MPGN. It was difficult for me to get this published. Eventually, we did get it published in small journal seminars of nephrology. You have to keep in mind when you look at this, you can just look at the diversity of the causes, okay? And you can imagine, I mean, if MPGN was just 1, 2, 3, infections need to be treated very differently from an autoimmune disease, and an autoimmune disease needs to be treated very differently from an dysproteinemia. So lumping these together under MPGN was blatantly wrong, because most of these patients labeled as MPGN type 1 who got steroids and other immunosuppression. And of course, sometimes they did okay, but if you have an infection or you have a dysproteinemia, that's really not going to help in terms of treatment and outcomes, okay? Of course, now we know better. We call this C3 glomerulopathy, and even C3G is now called C3GN. Of course, I don't like to use the terms 1, 2, and 3, although every now and then I keep seeing it because 1, 2, and 3 disregards the underlying etiology of MPGN. And now there are many papers that have come out on C3GN. And so the second half of my talk, for the remaining 10-15 minutes, I will focus on C3GN. We have written a lot about autoimmune disease, dysproteinemia, and infections as well, in the setting of MPGN. But I thought I would focus on this aspect of the MPGN for the remainder 10 minutes or so. Okay. So here are 5 patients, just to give you an idea. These are 5 patients. This last one is actually just one patient. And as you can see, this looks like an MPGN biopsy with double contouring. Same thing here, MPGN-like picture, 2 patients. Third one, this patient actually looked like an FSGS. There was some proliferation, but many glomeruli just showed segmental scars or segmental sclerosis. Here's one more MPGN. And this was MPGN on some biopsies, but again showed crescents in the other. So we had 5 biopsies on light microscopy that showed somewhat of a different picture, but on immunofluorescence, every case showed only bright C3, some more than the others, but you can see 1, 2, 3, 4, 5, bright C3 staining in the absence of immunoglobulin. So of course, they all fit with the C3G diagnosis. Electron microscopy, again, subendothelial deposits. So this would be your old type 1. Here is patient number 2. Patient number 3 showed you subepithelial deposits. In the old days, they may have labeled this as MPGN3. This one, again, mostly mesangial deposits, but a rare subepithelial deposits. And the last case had intramembranous deposits, so fit with dense deposit disease. So 5 cases of C3GN, but with varying positions of the deposits. So this is how we would have called it. 1 through 3, 4 would be C3GN, because these are subendothelial and maybe subepithelial deposits. In the old days, you may label this as type 3, and this would be dense deposit disease, okay? So that's 1 through 4. Now, the key is all of these 5 patients were worked up, okay? They were worked up for alternative pathway abnormalities, and the take-home message over here is the abnormalities in C3G can be extremely varied. yet determine the last thing that they form is this C3 glomerulopathy. So for example, patient number 1 ended up having a factor H autoantibody. Patient number 2 actually had a C3 NEF. And if I have time, I'll get into all of these in a little more detail. So factor H autoantibody in one patient, the other one had C3 NEF. The third patient actually had a mutation in this complement factor H. The fourth patient had a mutation in factor I, and the fifth patient of dense deposit disease had very high titers of C3 NEF. So what I'm trying to tell you over here is, even though all the patients show C3G on the kidney biopsy, the underlying abnormality in the alternative pathway can be quite varied. Okay, so not every patient is going to have the same alternative pathway abnormality. Just to give you an idea, we recently looked at 114. This is the largest series of C3G. We looked at 114 patients of in-house patients that were seen here over a 10-year period. And you can see that C3GN was much more common, almost 10 times, 9 times more common than DDD. Okay, so it's much more common disease entity. I'm jumping the gun here because of little time frame issues. So I'm not going to talk about complement abnormalities in great detail. I just want to show some important findings. When we looked at our cases of these 114 patients, what we found that if you look carefully at the history of these patients, almost every case you could find there was some trigger. Okay. Again, like I said, we deal with a lot of monoclonal immunoglobulin. So many patients had an underlying monoclonal immunoglobulin, mostly an MGUS sort of a situation. And if you dug around, the next common cause was many of these patients also had an underlying infection. Or you could get a history of an underlying infection. And the third one was some of these patients also had some sort of an autoimmune disease, sometimes not a classified autoimmune disease, but you would find they would have positive ANA titers, rare ones would have SSA or SSB, but they would have some story going on over there. So these were the 3 triggering events that was not uncommon to be found in almost every case of C3G that we dealt with. Now, I will just focus again, because of shortage of time, I will focus on this aspect a little bit, okay? When we tested our patients of C3 glomerulopathy we tested 95 out of the 114. I think the remaining 10 or 20 were not tested because they were really very young children. We found that 60% of the C3G did not have monoclonal gammopathy. On the other hand, about 30 to 40% of the patients had a circulating immunoglobulin. If you looked carefully at this particular group of patients, okay, this monoclonal gammopathy group, almost all the patients were older, okay? Greater than 50 out of the 36, 28 of the 36 were older than 50 years old. And if you work these patients up, what we found that most of these patients had autoantibodies. That means they had a C3 NEF or they had other autoantibodies. Genetic abnormalities were quite rare in this particular group. On the other hand, the younger patients tended to be negative for monoclonal gammopathy. And if you work these patients up, they could have C3 NEF and other autoantibodies, but they also were more likely to have genetic variants. So once you have a C3G and it's in a younger patient, more likely to be negative for monoclonal immunoglobulin, and they could either have autoantibodies or a genetic abnormality. On the other hand, an older patient greater than 50 years old, more likely to have only autoantibodies and very less likely to have a genetic variant. So sometimes when I get the question, the patient is 60 years old, has a monoclonal immunoglobulin, what should we work him up for? I always say, work the patient up for autoantibodies. You're less likely to find genetic variants. On the other hand, patients with CCG who are younger and you can test for negative monoclonal immunoglobulin, these patients are more likely to have genetic variants than this particular group. Okay, and the important thing, why is this important? Because the patients who have a monoclonal immunoglobulin, the disease tends to be much more progressive than your everyday C3G, okay? How does monoclonal immunoglobulin work in the setting of C3G? The thinking is that the monoclonal immunoglobulin acts as an autoantibody in all likelihood, or acts as a C3 nephritic factor where it stabilizes the C3 convertase, and as such, that's how it works and activates the alternative pathway. So this has not been proven, but this is the thinking, okay? And like I said, pathogenic variants are very rare in this subset of C3G and monoclonal immunoglobulins. I will tell you this again, the story goes back to the MPGN. When we first saw patients of C3G with monoclonal immunoglobulins, it was very tough to convince anybody that this thing was real. And this was again, I think in 2010, when we published this. C3G and DD were just being understood, and I would see many cases at the Mayo Clinic where patients of C3GN or DDD had a monoclonal immunoglobulin. And I remember writing to Jason and a bunch of other journals, and nobody accepted it until I had an invitation to write an article for AJKD, and then I put the story over there. And now, of course, it's a well documented and well understood cause of C3GN in the older patients. You always text for monoclonal immunoglobulins. Just to tell you, when you look at the C3G with monoclonal immunoglobulins, most of the patients fall under the MGUS group, what we would call now MGRS, but you can get an odd multiple myeloma or a smoldering multiple myeloma or even a CLL, okay? And the important thing is that this particular group of C3G with monoclonal immunoglobulin directs itself to clone-directed therapy. Remember, for the remaining C3 glomerulopathy, there is really no etiological-based treatment. I mean, we can give eculizumab and MMF and so on, but it does not target the underlying etiology. In the setting of monoclonal immunoglobulins, you can actually target the clone over here. And there are now a bunch of papers out there that show that clone-directed therapy would be helpful in this set of treatment. In our own little group of patients, you can see we had 16 patients of C3G with monoclonal immunoglobulins, and whenever you treated these with clone-directed therapy, if you got complete remission on the hematologic, there was complete remission on the renal function as well. Even if you got very good partial response, you got renal response. Even partial response of one patient with myeloma got complete renal response. On the other hand, if you did not get a hematologic response, the chances of getting a renal response was almost to zero. Okay. I think, I don't know where I am with time. The other thing is, I'll just, one last couple of slides. C3G and infections is another underlying etiology. Keep in mind, as maybe especially in the setting in India, many of these patients of C3G, if you look carefully, will have a history of infection. And the way the infection works, here is my hypothesis. In the normal situation, okay, you get an infection, the complement pathway is activated, but the complement pathway is very quickly brought back to normal once the infection is gone and you don't get any glomerulonephritis. On the other hand, patients who have abnormalities of the complement pathway, either low levels of C3NF or some mutations, when you get an infection, this is an autoantibody, or you have a mutation in the complement proteins. When you get an infection, the complement is activated, just like over here. But because of these antibodies or because of these mutations, the recovery is very slow. And as a result, you get persistent complement activation, and then you get what's called the C3GN. In the past, we would sometimes, the terminology persistent post-infectious or ongoing infection-related GN would be used. But truly speaking, these are all C3GNs because these patients often will have abnormalities in the complement pathways. So I am going to stop here. I know I could do more. Let me just go to some summary slides because this takes up time. Okay, I will stop here. I just want to drive home one or two key points. One is, keep in mind, MPGN is a pattern of injury. It's not a disease entity itself. The diseases can be immune complex mediated, and the most common ones are infections, autoimmune disease, or monoclonal gammopathy. On the other hand, it can also come from complement pathway abnormalities, and this can be mutation or antibodies. Rarely, especially in the children, I've seen an odd case of immunoglobulin, sort of MPGN, where we cannot fit this into any of these three criteria, and maybe there is a small idiopathic subgroup, But I would urge every time you see immune complexes, please work these patients up carefully. A small group of idiopathic subgroup may exist of immune complex disease. Going into more detail on the C3GN, it's characterized by bright C3 staining. You can subdivide it into C3GN and DDD based on the EM studies. More, like I said, shows MPGN. Often misdiagnosed at type 1, type 3, or post-infectious GN. The subgroup of C3G with monoclonal immunoglobulins is a very distinct subgroup. I, of course, did not go into the mass spectrometry details. In the end of the day, it's a very complex disease, and that's why you don't have any specific treatments. I mean, there is MMF story, but you have to keep in mind, I think the MMF works when you have more autoantibodies versus mutations. So it's a very complex disease because you can have multiple abnormalities, like I showed you, from mutations to autoantibodies. Similarly, there can be multiple triggering events. You can have an infection or a monoclonal immunoglobulin or autoimmune disease. And in the end, these two things come along and you get the C3G. On its own, infections, monoclonal immunoglobulin or autoimmune disease, I don't think they cause C3G alone. You have to have an AP abnormality there as well. So for example, in the case of infections, more often you have autoantibodies. Same thing with monoclonal immunoglobulins, you have autoantibodies. So you need the two things to go along, and then you get the entity of C3 glomerulonephritis. I will end over here. I would like to thank Richard Smith, without whose help I would not have been able to do these studies. And of course, Fernando Forvenza over here, who's a close friend and collaborator as well. So I will stop here. I reduced the talk. I did not go into the details of the alternative pathway complement because it's only 30-minute talk. So that's it. Thank you so much. Thanks again for having me.
Thank you, Sanjeev. As usual, excellent talk and changing the approach to glomerular disease by your original work. We have got many questions. I will take some of them. Dr. Mahakinder Singh from Chandigarh. Which all biopsy will you do unmasking before labeling as pure C3G?
What's that again? Sorry.
Yeah. He's asking which all biopsies will you do unmasking?
Okay, so
pure C3G.
So, there is this whole talk of some patients of C3G have monoclonal immunoglobulin deposits, and they're really not C3G. We see very small amounts of them. I have, in fact, done at one time did 37 cases of C3G in a row. I did unmasking. Unmasking you do with a pronase-based approach where you treat the kidney biopsy, the paraffin-embedded material with pronase to sort of unmask or make the antigens more prone to the antibodies. I found only one positive case out of 37. Now, the ones that tend to be positive always have a circulating immunoglobulin. So in my view, patients who do not have a circulating immunoglobulin, that means on SPEP or IFE, I would not do a pronase or unmasking. So in a child of 20 or a young man of 28 years old, that's unlikely to be positive, number one. Number two, the thinking is that the C3G with these unmasked deposits really is a fixation problem. So biopsies that are done fresh, for example, at the Mayo Clinic itself, and we get the sample, we do the cryostat, those are never positive for immunoglobulins, for masked immunoglobulins. On the other hand, prolonged fixation in the, when it's put in the mail for 3-4 days, it is sitting there, and a particular fixative, I think it's Zeus, can lead to masking. So they say it's not a real phenomenon, it is more of a fixation issue. So take-home message is that I would only do pronase in the older patients if they have a monoclonal immunoglobulin. In younger patients without any circulating immune complexes, circulating monoclonal immunoglobulin, I would not do a pronase.
Another question from Dr. Sabrinath from Lucknow, where you will put MPGN where both complement and immunoglobulins are negative?
So that would be a TMA. Typically, I did not go into this in detail, but typically thrombotic microangiopathy will also give rise to an MPGN pattern. Remember, the MPGN pattern comes from endothelial injury from either immune complexes, complement, or like I said, debris. So you don't necessarily need to have endothelial injury coming from only immunoglobulins and complement. So in the absence of immunocomplexes or absence of large amounts of complement, if you see an MPGN pattern, think of a chronic thrombotic microangiopathy. Typically in TMA, you can see small amounts of complement, but they are not as bright 3+ staining as you see in C3G.
Okay, another question from Dr. Srinivas from JIPMER. Is there any role of IgG subtyping in MPGN?
Yes, so if you get monoclonal immunoglobulins, like I said, under MPGN, you have immune complex or immunoglobulin mediated. If you get only IgG kappa or IgG lambda, sometimes only heavy chains IgG, in those cases, absolutely, you should do IgG subtyping. And then very often these will be IgG3 in the PG and MID, but in patients with CLL and B cell proliferative lesions, you will often get IgG1. Sometimes what happens is when I'm not very certain of an immune complex or even an infection-related GN, sometimes it's just small amounts of IgG, and I'm not sure whether it's kappa lambda, I will go ahead and do the subtypes in those patients as well. And as you know, if the patient has autoimmune disease, very often it is IgG1 and IgG4, small amounts of IgG2, 3 may be present. And infections, again, you will get, IgG1, or it can be varying, but it's typically IgG1 there. So you can do it, but more often it is done in the setting of monoclonal immunoglobulins to confirm your findings, okay? So that's what you do.
Okay, little out of the topic, but any comment on C4GN?
Okay, so C4GN, again, I did not cover, and I described this entity a few years ago. I've not followed it up. Every now and then I see one case. So it is my take on it is when you see the way I make the diagnosis of C4GN or C4DDD is when I see deposits on electron microscopy. So let's see, I get a biopsy. It shows some mild proliferative lesions and everything is negative. So IgA, IgG, IgM, C1q, C3, kappa lambda is all negative. And I'm usually ready to sign it out as a small, like FSGS lesion, or I don't know what's going on here. And then suddenly in the EM, I see lots of deposits. And the deposits don't fit with what the IF showed or what even the ProNACE showed. Then I do a C4D. I sometimes just routinely do it. And then the C4D lights up. It's like 3 plus C4D in the absence of everything else. Then you can go ahead and call this C4GN. The thinking, nobody has looked into this in great detail. The thinking is this is probably a lectin pathway abnormality. So keep in mind, we've been focused on the classical pathway, like immunoglobulin mediated typically is classical pathway, whether it's infection, autoimmune disease, or even the monoclonal immunoglobulins. And then we were focused on the alternative pathway, which is the C3G and the C3GN and DDD. Lectin pathway abnormalities alone, causing abnormalities have not been studied. And my feeling is in the next few years, or maybe, I don't know, somebody needs to work into it, look at these C4G patients and see if they have lectin abnormalities.
Last question is how to label atypical PIGN versus C3GN.
So I would not worry about that. Atypical PIGN or post-infection is really C3GN. It's just that these patients have a history of infection that did not, once the infection went away, the GN still stayed on. And when you work these patients up, they have alternative pathway abnormalities. So in reality, an atypical post-infectious GN is C3GN. It's just that they were preceded with a history of infection. And in other words, the infection was the triggering event. Truly typical case of post-infection disease would resolve in 2 to 3 weeks because these patients have normal alternative pathway abnormalities. So your garden variety of post-infectious that you see every day have normal alternative pathway abnormality. But if they have an abnormality, they have normal alternative pathway. But if you have an abnormality, then they would show up as a C3GN. And recently there were, I think, a couple of papers in JASN showing that these patients who have C3GN or post-infectious GN that persist have autoantibodies to factor B. So in a sense, they're truly C3GNs. It's just that the triggering event is an infection.
Last, just a comment, not a question from Dr. Ditambra. In Chandigarh, out of 91 patients of MPGN, they've got only one monocular. So there is a difference of etiology of MPGN in Indian context versus.
I agree.
Western.
I agree. That's why I always stress in the US, for example, where we live, at the Mayo Clinic, we have an older population. So monoclonal immunoglobulins are quite common over here. Okay. On the other hand, I think if you go to the East Coast and West Coast, where there's a larger Hispanic or African American Black population, probably lots more autoimmune disease. And if you go to India, you probably see a lot more infections. In fact, I have only seen one case of hepatitis in all these years. Very rare to see hepatitis or chronic infections. So obviously the etiology varies depending upon where you live.
So that's excellent, Sanjeev. On behalf of Indian Society of Nephrology, I thank you for your, as usual, excellent presentation and new data every time we come on there.
Thank you so much. Thank you for having me. Next time I speak on membranous, okay?
Okay, sure.
Okay.
With that, I hand over my the screen to Dr. Manisha for further taking the.
Yeah, thank you so much, Dr. Sanjay. Before we go to the interesting session of declaration of results, let me inform you that we had more than 600 registrations, and even now around 400 people were logged in. And the best interesting part of it, this is that not only people from South Asian countries, Sri Lanka, Nepal, Pakistan, and even Myanmar, we have the presentation from Saudi Arabia also. I hope this keeps interest of the people around. That's all because of our excellent speakers and of course the moderators as well. Over to you, Manisha, for declaration of results.
So thank you, Dr. Gupta. Thanks for the opportunity. I request Siddharth to put up the results. So you will be happy to know that we have had 158 people taking the quiz, postgraduates, all of them. Unfortunately, what has happened is some of them have posted the answers in the chat box. So it's okay. These things do happen. This was the first time, but others have answered correctly. So you don't only have to be knowledgeable, you have to be smart as well in answering. Doesn't matter. Don't get disheartened. So we'll come to the quiz results. Can I have the names of top 10 and the people, the top 10 who answered the questions first to that? Yeah, so you can see them here. Dr. Tanuj from Madras Medical College, third year resident. Dr. Anjana from Government Medical College, Trivandrum. Dr. Shashikant from Institute of Nephrourology, Bangalore, third year. Dr. Nitya from Madras Medical College, again, third year. Dr. Jaykumar from Sanjay Gandhi, Lucknow, second year. Kevin T. John, SRMC, Chennai, second year. Anjana, Government Medical College, Kozhikode, third year. Sahil Arora, Jipma, Pondicherry, third year. Ashwin, Kasturba Hospital, Manipal, third year. And Nikita Pawar, Sir Gangaram Hospital, Delhi. So congratulations to the winners. Wonderful. You did a great job. And the other people who have participated and scored well, as they have also done well. Don't get disheartened. Some of you posted the questions, as I said, in the comment box. So you were not marked for that. So unfortunate, it's okay. Better luck next time. So thank you for participating in large numbers. I hope the quiz was fun. And I hope after the 3 sessions, you have improved on your knowledge. We certainly did. Thank you. Thank you very much for the opportunity. And thank you all the speakers. Excellent presentation, sir. It's really a pleasure hearing all of you. Thank you. Thank you, Dr. Gupta. Over to you.
Thank you very much.
So this is the time to thank you all from Indian Society of Nephrology. And on behalf of all the members of the Indian Society of Nephrology, myself, Narayan Prasad, General Secretary of Indian Society of Nephrology. First of all, I would like to thank our 168 quiz participants, brave postgraduate students who have participated. And I would like to congratulate top 10s, all winners, and the best of luck to all the futures, rest of the PGs for all upcoming quiz in next few webinars. So we have planned for the years. So many sessions would be there, and don't be disheartened. Those who have not won, actually this does not discourage you, any one of you. Those who have participated are really brave postgraduate students. Thanks a lot, our international faculties, Professor Jai Radhakrishnan and Professor Sanjeev Sethi, always very close to the heart of all the Indian nephrologists and all Indian pathologists. They never deny to participate in any activity of Indian Society of Nephrology. Thank you, sir. Thank you. This was a great lecture.
Thank you.
As always, both of them are stalwarts in their field. Both are them never deny support to us. Thank you, sir. Thank you, Professor Vivekanand Jha, for enormous support to me and the Indian Society of Nephrology for bringing the face of the Indian Society of Nephrology on the international front. Thank you, sir, for sparing time for today's webinar despite your busy schedule, and there was some difficulty in catching flight, so we have little bit modified our program yesterday in the evening. Thank you, Professor S.K. Agarwal, sir, for your excellent moderation, for your time, always ready to contribute to Indian Society of Nephrology, and your contribution to the Indian Journal of Nephrology cannot be undermined. That is at now on the PubMed, getting some impact factor itself. So this is really I will like to thank you for all your contribution. Thank you, Professor A.K. Bhalla, sir, President-elect of the Indian Society of Nephrology. Thank you, Dr. Manisha Sahai and Dr. Santosh Varghese, my great friend, colleagues, and always ready. He is at present the treasurer of the Indian Society of Nephrology. He is a professor of nephrology in Madras, in CMC Vellore. So he always comes forward to support any good thing, particularly the teaching programs happening from the Indian Society of Nephrology. Thank you, Dr. Manisha, and thank you, Dr. Santosh Varghese. Thank you, Professor K.L. Gupta, sir, the President of Indian Society of Nephrology. You are always so interested to conduct any organization. Capability of this man is enormous. So anybody will say on the short time, he can manage everything, how it can be done in short notice. That is your credit, sir. Thank you very much for your time, your dedication for the Indian Society of Nephrology. In the last but not the least, thank you all the delegates. Thank you all postgraduate students who participated here in this webinar, and you have shown excellent moderation, excellent time flow. That was all that we required from the society's webinar in the future also. So thank you, everyone. Thank you for the joining. Thank you, all the members of the Indian Society.
Last word, Dr. Narayan, announce the certificates. The certificates of excellence would be given to the winners and even the others, the participation certificates.
Definitely. So we have just announced, thought that certificate of excellence will be given to all these top 10s, and all the rest postgraduate students will get the certificate of participation. So this will come by your mail, PDF format in the next few days. Those who will not get can contact me on my mail. So often or you might be getting so many mails from me. So I am always free to contact.
Dr. Ryan. These people, this is an event of participation of boys. Is a great event. It just gives a stimulus to compete, and I'm sure those the certificate of excellence from ISN, Indian Society of Nephrology, will definitely give some credit to and it add on to your CVs. And this is just a small thing, but it adds on. But before we close, it's my pleasant duty to thank our General Secretary, Dr. Narayan Prasad, who went with me in organizing this event all the way in a short time, but I think he did in a very good way and always very helpful. Thank you, Narayan, and thank you all. Thank you so much. And we look forward to further meetings as I discussed. I will communicate to you shortly what session we have and when we have. Thank you. Bye-bye.
Thank you, Sethi sir. Thank you. Thank you very much.
Thank you, sir. Thank you.
Thank you. Thank you, ma'am. Good night.
Thank you.
So now we can end.